Live from Town Square Towers at the heart of the Jersey Shore. Wake up with Jeremy Grunin. Get up, get out, do something. Join the conversation. 732-505-1160. News Talk Radio WOBM AM 1160 and 1310. Listen online at WOBMAM.com.
Hey, welcome back. Wake up with Jeremy Grunin, 7:07, Wednesday, December 7th, 46 degrees, getting up to 50 today. WOBM AM 1160 and 1310. News Talk Radio, streaming live on the Radio Pup app and WOBMAM.com, 732-505-1160 to join the conversation. We're now joined on the line by Dr. Frank Sharp. He is a vascular surgeon at Jersey Coast Vascular Institute and Ocean Medical Center. Good morning, Dr. Sharp. How are you?
Great, Jeremy. Good morning.
Good morning. So, tell me a little bit about yourself and how you got into vascular surgery.
Well, I always kind of knew I wanted medicine and I wanted to be a physician, and I guess going through medical school, surgery just attracted me more than the medical side. Some of my mentors in my training days were vascular surgeons, and I think I had tremendous respect for them, and I just ultimately wound up following that path. It's interesting. I come from a family of steam fitters, and vascular surgery is sort of the medical version of pipe fitting and pipe cleaning and bypassing and that sort of thing. But that really didn't have much to do with me wanting this profession.
That's kind of funny. So what do you mean? Because when we say vascular, what do you mean? What parts of the body do you deal with?
Well, vascular surgery, vascular disease refers to problems that occur in the arteries, which bring blood from the heart to the rest of your body, and the veins, which return that blood back to the heart. So if you sort of picture the heart as being a pump in the middle of your chest, and its purpose being pumping blood and carrying oxygen and nutrients to every part of your body, the arteries are those pipes that get the blood where it needs to go, and the veins collect sort of the used blood and return it back to your heart. So vascular disease refers to problems that occur on both sides of that system, both the arterial side and the venous side, or the vein side.
Gotcha.
And there are a number of different problems that we deal with. I know today we're going to be talking about problems on the vein side, returning blood and clotting in that system, but probably the most common or the most serious problem that we deal with would be clogged arteries or blocked arteries bringing blood to different parts of the body. Things that are, most people are very familiar with: hardening of the arteries, arteriosclerosis, atherosclerosis, all terms that mean basically clogging of that arterial tree.
Gotcha. Before we get too deep into it, so you're with Jersey Coast Vascular Institute. Where is that, and how big's the practice?
I came to the area in the 90s, and the practice has grown since that time. In 2001, we developed the Jersey Coast Vascular Institute, which was a vascular surgical or vascular practice only, and we came on campus at Ocean Medical Center at that time. Actually, the spring of 2002. So we've been on campus at Ocean Medical Center since spring 2002. We're a 5-person vascular-only practice, and we primarily service Ocean Medical Center.
Gotcha. Gotcha. So you started talking about some of the conditions that you treat. One that we really kind of want to talk about is DVT, which is deep vein thrombosis. So why don't you talk to us about what that is?
So I was trying to get you to have sort of a visual on this system of pipes that bring blood back to your heart. It's kind of a low-pressure system. It's pretty much promoted by just the act of walking, for example. So every time you take a step, your muscles in your legs sort of squeeze blood in these soft pipes and help return it back into your chest and to your heart. And the most common problems that occur on the venous side would be varicose veins. Most people know what varicose veins are. But on a more serious note would be when that system of pipes clots. So what I often say to patients is, if you can picture sort of a long, very delicate hose beginning at your foot and extending all the way up through the groin into your chest and connecting with one from the other side. Typically what's happening through that pipe is used blood, which is sort of darker than regular blood. So like grape juice floating through a pipe, going back to your heart, being promoted by every time you take a step. What DVT implies is a segment of that pipe, that grape juice has turned into grape jello.
Oh.
And it can be very extensive. It can be the entire piping system, the entire system from groin all the way to the foot, or it can be limited. It can be just behind your knee, for example. And so if you can just have that visual of a hunk of jello in a pipe where normally there's sort of a darker grape juice floating through there, heading back towards the heart, that's really what a DVT is. And of course, it does a couple of things. So if it's extensive, it will block the flow of blood back to your heart, which will make the limb swell and be painful. You're not returning blood normally, so the leg will tend to get swollen, and with that swelling is increased pressure, and it'll just feel heavy and it'll ache. But the most serious problem would be if that piece of jello, I keep saying jello because I think, from a layman's perspective, if you can sort of have an image of that, you might understand better what occurs here. But if you can imagine a segment of that clot breaking off, it has the potential to travel up that stream into the right side of the heart. And from the right side of the heart, the next path for blood would be into the lungs to get sort of a new round of oxygen. So if that clot goes in the right side of the heart and then into the lungs, it can obstruct the flow of blood into the lungs and cause something we refer to as a pulmonary embolism, which can be very serious. It can be life-threatening.
Right. I guess you threw me off, though, because I was always taught as a kid that there's always room for jello. But now you're telling me that there isn't always room for jello.
Well, the jello, the likelihood of the jello breaking off and going to the lungs is pretty remote. It's probably 1 in 10. It's probably about 10%. So it's not as if it's going to happen every time.
Right.
But we can't predict when that's going to happen. So we treat the clot aggressively when we know it's there.
Yeah. Well, listen,
prevent that.
I think we all have to look at jello differently anyway, because as we'll all recall, when we were kids, and I don't know how old you are, but when I was a kid, the spokesman for jello was Bill Cosby. So I'm all blown up about jello anyway. So let's move along. Who's at risk for DVT? Is there an age issue? Does it matter?
Yes, it does. Today's medical world looks at DVT. We sort of look at patients in one of two categories. And it's important for us to kind of identify a patient as being in one of the two categories, and they would be the following. The first would be what we would call a provoked category. So if we make the diagnosis of a DVT in a patient, if it's provoked, it means that we can identify something that may have caused it. And the second group of patients, and we can talk about that in a little bit, would be unprovoked. So the unprovoked patient would be someone who all of a sudden one day wakes up with swelling in a limb. They go to their doctor, they get an ultrasound, they're diagnosed with a DVT, and we have no idea why. There's just nothing that precipitated it that we can identify. So to get back to the provoked category, which is I think what you were asking about, there are a number of things that are commonly provoking factors.
Okay. Well,
hospitalization being a huge one.
Okay, Doc, I'm sorry to cut you off, but before we get into that, we are up against a break. So when we come back, let's kind of talk about those factors and conditions that increase the risk of DVT. Is that okay?
Sure.
Awesome. Dr. Frank Sharp, vascular surgeon, Jersey Coast Vascular Institute and Ocean Medical Center. Back with more Wake Up with Jeremy Grunin right after this.
Stay tuned for Preferred Company with Joel Markell and Marianne Levy at 8. Wake Up with Jeremy Grunin continues next. News Talk Radio WOBM AM 1160 and 1310.
Hey, welcome back. Wake Up with Jeremy Grunin, talking to Dr. Frank Sharp, vascular surgeon, Jersey Coast Vascular Institute and the Ocean Medical Center. So we were talking about factors and conditions that increase the risk of DVT before I so rudely interrupted you so that we could pay our bills. So go ahead, Doc. So what else do we have? What kind of factors and conditions?
Well, the first thing I would say is hospitalization is a high risk factor. And what I mean by that is if you're hospitalized, you're often immobilized for a variety of reasons, stroke, heart attack, surgery, injury, etc. So the process of being immobilized, laying in bed for several days, is a risk factor. Having a joint replacement is a risk factor. Having major abdominal or chest surgery or gynecological surgery, all of these things put you at risk because of the immobilization factor and the fact that you're not emptying the blood out of your legs as you normally would when you're walking. Catheters, people that have central lines and catheters for chemotherapy and that sort of thing. Chemotherapy in general is a risk factor. Cancer is a risk factor. As I was talking about joint replacements, but even things such as arthroscopic surgery, fractures, being immobilized because of a cast on your leg. So when you interfere with the ability of the calf to pump that blood back to your heart by laying in bed or by not being able to walk properly or not being able to move your foot properly, all of those things put you at some increased risk. There are also some other things that are not as common, but estrogen products. So young girls on birth control pills are at an increased risk. Women on estrogen replacement. There are some drugs used for breast cancer and different malignancies that have estrogen properties to them that put patients at risk. Pregnancy is an additional factor. So there are a number of things that can provoke or put someone at risk for getting a blood clot.
Right.
I mean, I may see somebody in the hospital today, and they came in and they may be in for some other reason, and the doctor noticed that one leg was swollen, and they did an ultrasound and they find a DVT, and we're trying to find out what may have put them at risk, and we find out that they were hospitalized 2 weeks ago at another hospital for a week because of some other condition. That would be the provoking factor for me. Sometimes it doesn't take any more than that.
Gotcha. What about age or smoking or being overweight? Any of that contribute?
Yeah, all of those go on the list. There are formal risk assessment models out there that apply points for how great the risk is. So if you look at things such as risk based on age, the older you are, the more points you would get, essentially. Same thing with weight. If you're heavier, you're going to be at greater risk. Tobacco is also a risk factor. I wouldn't say that tobacco alone would be something we'd very commonly see causing a blood clot, but it certainly is one to add to the list. And I think there are patients that present with phlebitis or deep vein thrombosis that have sort of maybe it was a perfect storm. Maybe they were dehydrated, they're overweight, maybe they just got off a plane where they weren't moving around too well for several hours. And we don't come up with much else, but
right.
They wind up with a DVT.
Right. So how do you treat it?
Well, the treatment of it is probably one of the reasons we're talking today, because the treatment's changed a little bit. But the primary treatment is to put the patient on a blood thinner that prevents that clot from extending or getting any more substantial. The jello concept again,
right.
From preventing any more jello from forming in that pipe. And what that blood thinner also does is prevent that jello from breaking off, that clot from breaking off and traveling upstream. So blood thinners, strong blood thinners, not drugs like aspirin and Plavix, which are sort of a different class of blood thinners, but drugs like heparin and Coumadin and some new drugs that we can talk about are about 98, 99% protective in preventing the clot from extending and preventing it from breaking off. So that's the standard of care. It's been that way for 40 or 50 years. What's new today, and I don't want to get ahead of ourselves too much, but what's new today are some new drugs that have made it a little bit easier for us to treat patients as outpatients.
Right. Right. So first of all, but signs and symptoms is it easy? How would I know when I should go to the doctor?
The most common symptom that would be fairly obvious would be one-sided swelling in a leg.
Gotcha.
So if all of a sudden one leg is swollen or one calf is really sore and you weren't at the gym, you don't think you pulled your gastroc muscle or the back of your calf, that would be, to me, one of the most common things you could look for as a patient and say, well, if something's not right here, I better get this checked out.
Right.
Now, The other thing to keep in mind is and I haven't really talked about this, but that whole unprovoked category, that group of patients that we have no idea why they develop the clot, in those patients we start looking for things in their genetics that put them at risk for clots. And there are a number of different clotting factors that patients can have that, can make them high risk for developing a DVT. So if you have a family history, if you have a sibling or a parent who had a DVT in a leg and was on blood thinners, and I would be cautious with the history because a lot of patients will say, well, yeah, my father had a heart attack or my mother had a stroke. That's different. But if they had a DVT in a leg or a DVT or a clot in a leg that went to the lungs, that family history is extremely important. So if that patient one day wakes up with swelling or unexplained pain in the calf muscle or in the limb, I would not play around with that. Gotcha. I would go right to your doctor.
Gotcha. And obviously, if you present with symptoms, you probably should contact your doctor right away and seek medical help. When we get back, one of our listeners wanted to know if you can't walk, what's an exercise that'll help? And I also want to understand, you alluded to a new approach at Ocean Medical Center. We'll talk about that when we get back. Dr. Frank Sharp, vascular surgeon, Jersey Coast Vascular Institute, Ocean Medical Center. Back with more after this.
Wake up with Jeremy Grunin. News Talk Radio WOBM AM 1160 and 1310. Live from the Jersey Shore to the world. Get up, get out, do something. Wake up with Jeremy Grunin. Take the show wherever you go. Download the free Radio Pup app for your smartphone or tablet. Join the conversation. 732-505-1160. News Talk Radio WOBM AM 1160 and 1310. Listen online at WOBMAM.com.
Hey, welcome back. Wake up with Jeremy Grunin, 7:34, Wednesday, December 7th, 46 degrees, getting up to 50 today. WOBM AM 1160, 1310. News Talk Radio, streaming live on the Radio Pup app and WOBMAM.com. 732-505-1160. We have Dr. Frank Sharp, vascular surgeon, Jersey Coast Vascular Institute and Ocean Medical Center. When we went to break, we had one of our callers call in and ask if you can't walk, what can you do as a preventive kind of exercise?
Well, if you're not able to ambulate, the one thing you can do that sort of mimics walking would be to what we call plantar flex your foot. So it's basically pushing your foot down as if you're pushing on a gas pedal in a car. So if you can flex or contract your calf muscle, that mimics walking.
Gotcha.
That's probably about the only thing you can do if you're not up walking to help. The other thing you can consider is wearing an ACE bandage or a stocking on the leg. That'll decrease the risk a little bit. I don't know if I was clear before. This whole idea of immobilization that occurs in the hospital. That's a big part of what puts patients at risk. But there are a lot of other factors: infection and surgery, and turning on the clotting mechanisms when patients have surgery. So there are a lot of other things that are happening in a hospital environment. In addition to the immobilization that puts those patients at risk.
Gotcha. Doc, we only have about 5 minutes left, and we have some ground to cover. So talk to me about the new approach that's in place in the emergency department at Ocean Medical Center.
Okay. Well, 10, 20 years ago, if you developed a blood clot, you would come in the hospital, you would be put on intravenous heparin for 5 days and converted to Coumadin therapy, which takes about 5 days for the blood levels to be adequate. So you'd be in the hospital 5 days. Minimum. What we have now are oral blood thinners in addition to Coumadin that work immediately. Again, Coumadin would take about 5 days before the levels were adequate enough to stop the heparin. So with the advent of these new drugs, we can, in some situations, assess a patient in the emergency room and send them home on that medication. Now, that sounds kind of simple. From my perspective as a vascular surgeon, there's tremendous risk involved. We need to make sure that patient was properly assessed, that there aren't any other conditions, that they understand the process and what's wrong with them, that they understand the risks of being on these blood thinners. You see commercials all the time about the risk of bleeding. So to come up with a process where someone could show up in the emergency room with this diagnosis and go home and be safely treated and understand exactly what they're up against, to me was a little daunting. And, with the coordination of our emergency room staff and our pharmacy here at the hospital, we've been able to develop a protocol where I think we have all bases covered. And essentially what happens is the emergency room doctor assesses the patient. They contact our group. One of us calls back. We review the case. If we think they're an appropriate patient to be treated as an outpatient, they're given the drug. They're given a 1-month supply before they leave the emergency room. So we know they're not going to go to a pharmacy that afternoon, not be able to afford the treatment, and not start on it. And then we contact them within 24 hours, and depending on the situation, we see them in the office within a few days and dot all the I's and cross all the T's and come up with our long-term plan. So we've been quite comfortable with it. It's kind of unique in that we're here on this campus, so we can have oversight and make sure that we don't see a patient in the emergency room and send them out in the world and have something happen to them or never follow up with them.
Gotcha.
But that's pretty much what I'm trying to give it to you quick in case we run out of time.
Absolutely. Very quickly, pulmonary embolism, what is it and how is it connected to a DVT?
So, again, the DVT being this clot in the leg.
Jello.
About maybe 10% of the time can have a tendency to break off and travel upstream into the lungs and sort of block some of the blood flow into the lungs. If it's a small piece of jello, it would not be so significant. You might have shortness of breath. You might feel a little anxiety. But if it's a large amount of clot, it could theoretically, cause someone to expire. I mean, it can be life-threatening. So if you have that family history of DVT or pulmonary embolism, and one day, you're starting to feel short of breath, even without a symptom of swelling in the leg, that would be another indication to really contact your doctor right away or even potentially go to an emergency room.
Gotcha. Okay. So I'm going to roll through this part real quick here. If you have concerns and you want to talk to your doctor, what are some of the things that you should be prepared to discuss? What should they kind of know before they're calling or checking in with you? Well,
they should be aware of their family history, if they have a family history of these type of conditions, of the symptoms that they're having. There are a lot of great sources out there to read about this kind of information. If a patient's interested, I would advise them to go to reliable sources like WebMD. The Society of Vascular Surgery has a tremendous website that has a lot of information, the Mayo Clinic website. And typically you'd start, if you're having these type of symptoms, with your primary care doctor. You wouldn't jump to the specialist level. That would be the starting point.
Gotcha. And make sure you know your medical history, upcoming surgeries, current medications, weight, and physical pain. For more information about vascular services at Ocean Medical Center, you can visit www.oceanmedicalcenter.com. Or, of course, you can call directly to Dr. Sharp at Jersey Coast Vascular Institute at 732-202-1500, right?
That's correct.
All right. Dr. Frank Sharp, vascular surgeon, Jersey Coast Vascular Institute and Ocean Medical Center. Thank you so much for your time this morning and for dropping some knowledge on us about DVT.
You're very welcome, Jeremy.
Have a great holiday, okay?
Thank you.
All right.
You
Wake
too.
up with Jeremy Grunin more after this.